Hi, everyone. I'm Diana Yan. I'm one of the pediatric ER docs at Mount Sinai Beth Israel in New York City. So I'm excited to be moderating this session entitled Mixing QI with Latent Safety Threats, QI and Latent Safety Threats with Simulation. I'm going to first introduce each panelist separately, and then the panelists will talk about one of their QI sim-based projects, and then we'll open it up to the audience for questions. And then we're also recording these so that we can post them for the group at large. All right, so Susie Bentley is the Director of Simulation Innovation and Research for New York City Health and Hospitals, the Chief Wellness Officer and an Emergency Medicine Physician at New York City Health and Hospitals, Elmhurst. She is a Professor of Emergency Medicine as well as Medical Education at the Icahn School of Medicine at Mount Sinai, and is the current president-elect of Simulation Academy. She's passionate about quality, safety, and the healthcare worker well-being and their integrated roles in healthcare. And Preeti Jani, she is a pediatric critical care physician who takes care of critically ill infants and children in the ICU and pediatric sedation service at UChicago in Chicago, Illinois. Dr. Jani's scholarly focus lies in the intersection of research in simulation-based medical education and resuscitation quality improvement, with an interest towards improving individual, team, and system-level performance. She is the serving chair of Pediatric CPR Committee and Pediatric Resuscitation Quality Committee, as well as the faculty director of the UChicago Simulation Center. She is highly invested in using SIM to further advance education, safety, and quality at UChicago, as well as Comer Children's Hospital. Today, she's going to be talking about her project entitled Uncovering Hidden Safety Threats, System-Focused Simulation to Enhance Clinical Preparedness and Patient Safety During Pediatric Sedation Transport. And then Dr. Stephanie Stapleton is an assistant professor of emergency medicine through Boston's University School of Medicine, and she is extremely well published within simulation, and it's no surprise that she is also the chair of the SAEM Sim Academy Research Committee. Her area of interests are in latent safety threat mitigation as well as process improvements. Today, she's going to be talking about her QI project on precipitous deliveries in the ER. So we'll have each panelist talk about their project, and then we'll go into questions afterwards. And I'm sorry, Steph, I was going to say the entire name of Boston University, and then I chickened out at the end. My brother actually goes to BU for med school, so I actually asked him to record it for me. And when I saw the actual thing, I was just like, oh, I can't do it.
It's a mouthful, and clearly there was a large donation, so BU is fine.
Yeah. No, he told me the whole story. He has like their jacket, their gear, all of it. Okay, we'll go into each person's talk for a couple minutes about each project. Whoever wants to go first can go first.
Okay, well, first of all, thank you for having me. I'm going to share a project that came up a few years ago at our children's hospital, where we were asked, unfortunately, to sedate our pediatric patients in a different location. So normally they're sedated in the first floor of our children's hospital, and instead we had to temporarily prepare to transport them. And these were both PICU, NICU patients, some intubated, for our MRI to transport them from where you see point A, which is our children's hospital, to go underground through tunnels that cross underneath that street and into building B, which is an adult space. And so this obviously brought up several questions for us and concerns. To plan the simulations, we had to understand this very complex system and all of its moving parts. And so to do this, we use SEEPS, a healthcare human factors framework, to really think about the components around the person, the technology, the equipment, the education, the processes impacting care, and then develop simulations integrated into the framework for this system. And I'm going to fast forward because I think these got switched around. So we work together with our PICU, NICU, Sim Center, Respiratory Therapy, nursing, and educators to design these multiple in situ simulations spanning 2 days. And we use SEEPS as our framework to sort of design these scenarios. And then we had post-simulation individual and group debriefing scripted, really to emphasize a safety 1, what went wrong, and a safety 2, what went right approach. So during the debriefing, team members identified latent safety threats, mitigation plans, opportunities to further optimize the system and team performance. And then expert and consensus and hazard scores were used to prioritize those interventions. In total, we identified approximately 33 latent safety threats spanning multiple SEEPS domains. And I'm going to kind of share some of those with you guys. So again, the scenarios were mapped to our objectives. For example, for a dislodged ET tube, we were looking at, what does our bag valve mask ventilation readiness look like, our equipment, our airway bag, the care process for intubating in the tunnels, as well as things such as like calling for help. So as you can see here, we looked at endotracheal tube obstruction, airway obstruction, lost PIV, contrast reaction, trach dislodgement, and we conducted these scenarios, some of them en route, and then we also tested out a day in the actual new space. I'm sorry, these are out of order. So we've discovered multiple latent safety threats, as I said. So in the category of person team, we identified roughly 12 threats. The most significant were that our code responders actually had a really hard time finding us in those tunnels. And what we thought was supposed to happen, which was that pharmacy ordinarily would bring the crash cart, they also had trouble. And so this led to some mitigation plans related to signs posted throughout the tunnels so that we could identify to our paging operators where we were located, creation of emergency medication kits that are now being taken to each transport. We also found many missing supplies, things such as medications for reintubation, albuterol needed for anaphylaxis. In the adult space, we didn't have AM needles to give the IM-epi, warmer packs for NICU transport. So this resulted in the generation of a transport checklist. We also found knowledge gaps around our equipment. So we had some education and equipment refreshers. And then simple stuff that we hadn't thought of had we not done the sim, such as, teams lacking badge access to the MRI. So if there were an emergency, they would not have been able to get in. And lastly, in the physical environment, we had 5 threats. And then in the category of care processes, we had approximately 8 threats, which are the ones that I've gone through. So after doing this, we quickly realized the importance of doing these types of sims into our and integrating them into our PDSA. It really became clear that we needed a vehicle to move us from our work as imagined or how we thought things were supposed to go to using simulation or work is simulated to seeing how things should be done to reveal how that work actually would be done in a better way. So we now incorporate this framework into our nursing comps and anytime there's a new process to evaluate. So all of our nursing competencies are sim-based in situ, where these exact same pathways, routes, spaces are being tested in sort of a similar way. And it has been really fruitful in identifying both latent safety threats, but also the opportunities for improvement. And I think that is sort of the end. So in some, really using simulation as a learning lab for education, quality improvement, and safety. And what we see is that there's really this bi-directional feedback loop between the learners and the healthcare system. So in sim, we're learning from the system and educating or changing the system based on what we learn, what we identify to be most optimal. And using a system-focused sim with a framework such as SEEPS, but there are other frameworks that exist, has been really helpful in integrating that into our debriefings to really be able to maximally extract the knowledge from the system.
Perfect. That was a really good summary of the project. I'm going to try to find a link for SEEPS and put it in the chat for everybody. All right. So our next person is...
All right. So I am far less prepared and I do not have slides. So it's a little hard. We should have had you go last, but I'm excited to also share a little bit. And I was struggling when Diana asked me which project I wanted to talk about because I wasn't necessarily sure. And I should, full disclosure. So I actually got onto the root cause analysis team at our hospital about 8 years ago because SIM was really emerging as this sexy new thing that no one totally understood. And every single corrective action coming out of quality seemed like it was a simulation. And a lot of them were totally unnecessary and not appropriate. So I said, why don't I help and get upstream? And that was a lot of how I got so kind of ingrained in quality and safety, which I absolutely love. So I think I want to talk a little bit more about process, if that's okay, instead of, I'm not going to go through any fancy data, especially following Preeti, but some of the big things I'd say that I've done for quality that I think are probably the most interesting have really been around, we always say it's no more see one, do one, teach one, right? It should always be simulated first, is really being very deliberate about everything should be simulated, the process, the team, the new equipment, all of the above. And that is kind of a culture change from a lot of things. So I think for quality and where I've had the most success is a lot of what I've done is really teams, but teams within teams. So a lot of cardiac arrest simulation, a lot of trauma team simulation, a lot of stroke team simulation, and getting very, very deliberate in taking it and breaking it into really tangibly manageable layers and then ramping up to doing the full scale sim. So when I tell people, we did this red trauma, which at our site is, like high acuity, everyone in the hospital shows up, trauma, they're like, how do you manage that? I couldn't even imagine running it, let alone debriefing and keeping track. And we actually published a little bit about this ramp up, but we started doing green trauma, which is really just the ED. Then we started doing yellow, which is the ED and a surgical consultant. And then over time, did a red with anesthesia, then, got to the point of red with all the specialists with neurosurgery and ortho. And again, these are all in situ, always in the real space, because I think it's very, very hard to pick up latent safety threats without putting people in the pressure cooker of where they really are. And then trying to, capture the themes. And even stroke sim, like to most of us, I imagine that sounds incredibly boring. And why do we need that? It's very algorithmic and it's something in the ED we do, day in and day out. But we had some new guidelines that rolled out, across New York City. So that was why we started doing them. And in doing them, we started picking up amazing latent safety threats. So we've always been gold. We've always, with the guidelines, had no issue with the metrics. But then you started to see all of these amazing ways things could actually be done safer or faster, higher quality. And then taking it from basic to just even the EMS handoff piece, we realized was a huge opportunity. And then what do you do when it's the crashing patient, that needs to be intubated, that's brought in by a BLS unit without access, and kind of ramping up though very deliberately to that stage and then doing it enough times to capture it. And then because of the familiarity with that, we were able, when we were going up for thrombectomy certification, to use simulation for everything from where the machines were going to be placed. Then once they were in, no more cardboard boxes that we stood around for the sim. Once they were installed, literally we would just simulate people coming into the room and where the team members were standing. Someone almost fell, they didn't get hurt in a sim soon before it actually went live. And that was just because no one had actually gone in there once the wires from all the anesthesia equipment were actually in. So picking up all sorts of latent safety threats, both subtle as well as, pretty obvious. And now actually for one of our sister hospitals, we're about to roll out in situ telesim because they don't have neurology all of the time. But it's gotten to the point in the culture where it's like, oh, we wouldn't do telesim with this platform until we'd simulated it enough and let the providers, everybody get comfortable with it. For code sim, again, a lot around the themes, but we actually, put it into the hazard matrix, looked at the themes we were seeing. And then from that, we actually, in addition to making things safer by partnering, you have to have the machinery to fix and the commitment to fix what you find. Otherwise, you're just going to hurt your program and lose your buy-in. But we actually took it and we created a, we called it a threats curriculum for leaders. So all of our new cardiac arrest leaders, which is just escalating years of residency, then get put through. And it's deliberate practice, these 7 threats to leadership that we saw over these 74 in situ codes. And they love it because it's like quick and dirty and deliberately puts you into the situation with the new nurse that's not quite sure how to use something, whatever it might be. And then in doing the sims, looking at it before and after, people communication scores, teamwork scores on some of our metrics actually improved just from that. So it's often about just being deliberate and almost being kind of basic, like maybe that is not that exciting, but what we learn, we actually then were able to translate into a far bigger educational opportunity, which I personally thought was exciting and kind of a win-win. And I will leave it at that. Steph.
All right, thanks.
Oh my God, all that sounds amazing. Did you guys publish all of your stuff? And if so, put it in the link if you don't mind while I'm chit-chatting a little bit, because I'm learning so much just being here. Yeah, same. I'm thinking all the time that I've done little bits of, the CRM techniques with leadership, but finding the actual areas for improvement, especially with all the new nurses on board, that's a whole different ball of wax. So I'm going to talk about my one project. Really, I started at the opposite end. I did the early era of starting with an incredibly complicated project right before COVID. So it's been long lasting, more than we thought, and definitely lessons learned, but it's been really interesting. So 3 of us, some leaders at my hospital, got together and came up with the idea of looking at latent safety threats and precipitous deliveries. Really, I heard about it and joined the club because I thought it was a great idea. And it's me, the director of EM SIM, it's the director of pediatric SIM, and director of OB SIM at my hospital. And we wanted specifically to hold this insight to, of course, to really look at the latent safety threats within these really high acuity events where we actually have all the services we need, right? It's an academic center, but frankly, everyone is always freaking out. No one's ever quite ready, even though it's part of our scope of practice. And there's so many people in the room, it just ends up being a cluster, and you wind up as an ED attending, you have to your job strays further and further from managing the patient to managing the 50 million people in your room who are constantly going in and out and talking, etc. So definitely ripe for improvement. And so that was the concept. There are a lot of devils in the details when it came down to okay, what are, how do you choose what cases are you going to do? In this case, it's precipitous delivery, right? There's a couple different options, but really the big ones are postpartum hemorrhage and eclampsia, preeclampsia going into eclampsia. However, this was also dealing with not just a sick mom, but a sick child, right? So you needed both those elements, and really to highlight what teams are taking care of these, where are the patients going to be? We have 3 trauma bays. Where do they actually end up? All those millions of different variables within that regard. And then because we wanted this to be more of not just a QI, but also a research study, we wanted to video and audio record and get people's feedback on the actual event. So the learners here went in and did it. So this required a lot of deliberation, a lot of practice runs, a lot of practicing where for example, with audio video recording, things I never thought about, where actually do you put the audio and video recording, oh my God, equipment, so that you can actually pick up what you need and how many of those do you need. And you can't always predict where people are going to stand. So how do you actually capture it? And the noise level in the room is just so loud. After having watched all these, you'll never be able to capture one thing on one camera. Some people may have a top camera, but really being able to watch that all the way through the people, if you're going to have them evaluate the video and the audio recording, can they actually hear and see what they need to do, etc. So you really need to beta test that version before you even get to beta testing, or what I like to call the first pancake run, right? So let's say you've done all that organization, you know where your cameras are going to be, your sim crew, everyone has to be on board, right? And I'm just talking about the sim organization and the cognitive element. Making sure your departments and your hospitals, et cetera, is on board is a whole different ball of wax, which I'll talk about in 1 second. But when you go through that first run where you finally bring everyone together, for example, we did it was the first run post-COVID. OB was concerned about coming down because the risk, because it wasn't really right. It was mid-COVID. It was after everyone's vaccinated, but everyone's still worried. No one really knows what's going on. So we tried Zooming in OB. Do you want to? Oh, no, it was awful, awful, awful. So that was our first pancake, so to speak. No one could hear anything. There's a lot of frustration. Never doing that again. So you'll find out, people move in these unpredictable ways and all of your cameras are blocked. And so it's not really useful for research. You can use it for getting people's evaluation, but not actually doing the video review. So that's sort of the sim-based element. And then the other is getting everyone, you have your learner, your department, everyone else. Our ED department is pretty dang big. And so as many people are, right? So the residents all love sim, etc. The students get it. Most of the attendings get it, but nursing, while they use it for training for CPR and things, they don't really have enough educators to do it and to understand that, when you go in and do it in psych, you act like you normally do. So I very naively was hoping to have sort of a contagious effect, oh yeah, this is what we do. We just go in and we do it. And I was there to kind of real-time coach, but it was definitely a bit of a stumbling block as far as that goes. So just something to consider. Also, I realized I was like, I can't really train 300 plus nurses to like accept sim into their lives. Like that would have to be a nursing leadership, et cetera. But as time goes on and nursing elements change, more and more people are becoming interested, involved, and really appreciate that chance. So there's just buying, and you can stop me if I chat too much, please. You can be like, stop, go ahead. There's getting the buy-in just to practice, but there's also getting the buy-in and the text, I should say, right? Everyone, the buy-in of the research angle, which is very, very tricky. Again, like docs, no problem. Students, they all get it because you have to go through and consent because it's audio and video. Nursing is understandably much more concerned about, because what are they worried about? That they're going to be caught doing something bad or inappropriate and lose their job because it's a different culture. So you have to be very clear about addressing that. And a number of nurses who are just like, I'm not comfortable doing that. And thankfully I found other people who like weren't on the trauma team but would try. Very few of those people with a lot of, but that's something to really think about, and like a very understandable, reasonable concern in there. And being very clear and very deliberate that will never be shared with their leadership. There'll be no information, any individual, and that this is not about what they are doing, but rather finding systems, things which kind of lead to my learning pearl number 5,000 of this, which was, I was of the impression that we were doing this to learn about latent safety threats. My two other collaborators thought they wanted to look at how well people adhere to different algorithms. That's fine for OB. They have like a postpartum hemorrhage algorithm and an eclampsia algorithm. PEM has, there's like a very clear neonatal, like NRP, neonatal recess program. There's not a clear algorithm per se for postpartum hemorrhage or for eclampsia in the ED, and nor do I necessarily think there should be, because a lot of this is just about recognition and coordination of efforts, and for our angles, like, are they recognizing the severity, and are they actually paging who they need to page? So that's been a different hurdle for me as a researcher, etc. And then thinking, this kind of goes back to the whole thing very deliberately, right? Time and space is so valuable in the ED. No one really hit on this, but there has to be some sort of like rules of engagement, and there's many papers about this. I wish I thought to compile them before, but figure out what your rules are of engagement are going to be. The culture in the ED is just gotten harder and harder to do any in situ work in, just because I jokingly say I'm surprised we haven't moved to bunk beds, but any day now expect it to actually happen, which is crazy. There really isn't any room or space, but you can squeeze out these little bits and pieces to do it. So every minute that you're using, you better dang well be using it well. And part of that is getting buy-in from the charge nurse, from the nursing manager. Like everyone had to be on board for this to happen and understand the reasons for it to happen. But also with that in mind, it's not just the sim, it's the debrief. So I was very adamant that like we will not do more than 10 minutes, given the complexity of the sim, because we had to have enough time for mom to deliver, for them to deliver the baby, and for them to recess both mom and baby. So it was pretty good. I was pretty much like, we're going to time this out. This is about as quick as we can do it. You could break it down to smaller bits if you wanted. But also as far as debrief, and we wanted to get like some evaluation, I just said we're going to do plus delta, because there's like 20 plus people in the room, and we're each team, like we're going to get 1 plus delta from each, like the OB team, the EM team, the PEM team, and NICU if they come down. So creating it that way. Oh yeah, no go or not right now criteria, definitely. For instance, if there's a bunch of, I work in Boston, if there's a bunch of shootings, and I'll come in at once, like that's just not the good time, right? All you're going to do is, no pun intended, but shoot yourself in the foot and your program in the foot. Versus, often we would just kind of wait half an hour or so and things would clear up. Sometimes they wouldn't figure out what the low time is, and when people are available to do it, that's really key. The other thing I would think that really you want to think about in your study design, and was a learning lesson for me, is don't just report latent safety threats. A lot of the times people actually know what they are, and it's frustrating that there's so many systems issues. It can be incredibly frustrating. And a lot of times people know what they are, they just lack the resources to deal with them, or a good idea worth. So consider a way to approach them and be like, this might, what do you think about this fix? Is this reasonable? Is this something to work on? So for example, with us, a big one was just the simple way to page the like true OB emergency, like I need you here now page, was just an atypical way to do it. So, if we have a code stroke, a code STEMI, whatever it is, you call a specific hospital number, you say, I'm activating a code STEMI or a code stroke. So my idea was to be like, can we just have it be a code OB, code baby, or something like that? And so that actually got created, which is amazing. But all the work I did was like running these and identifying it and running it by people and seeing if it seemed a reasonable option. I think there were like 70 people on that email to make that happen. It was insane. It's insane. Like, that is nuts. And then we did sort of the implementation sides to make sure it all worked, etc. So things like that, because otherwise you're just kind of the Debbie Downer a little bit, and it makes a good paper, but it also makes people feel bad. So it's nice to come up with potential solutions and other things like, you know what, we just need a really simple, like we have the big fancy OR L&D kit, but like, dear Lord, I don't need all that crap. I need like scissors. I need a couple umbi clamps. You know what I need are like towels and a place to put the placenta. Very basic thing. So working on that next. And I think I'm just going to reiterate, you will learn. I mean, this is one of the cool, interesting / scary things about sim. You will just learn so much about what people think they do versus what they actually do. Constantly, just constantly, myself included, right? If I could, I mean, I've definitely been on the other side of sim where I'm like, I thought I would do something, I just didn't, but I'm used to like observing and being an attending now rather than being the person primarily doing it. So I think that is golden, and whatever you can do to bring out that moment and help the group as a whole reflect on it, or the systems or whatever. I think my only last pearl is like, this was like a year out of residency that we, not residency, fellowship, that we started this, and I so underestimated how much work this was. Oh my God, I had no idea. And I was sort of flying around on my own. In retrospect, I wish I would have talked with some other people to figure it out. It's a good project, it's a reasonable one, but maybe we could start at a smaller scale and then figure it out from there. So, and like, we're still working on the first publication from it. So there's a little bit, there's sort of like the real-time QI, patient safety learning, and then there's sort of the research and scholarship portion, which I think probably needs to be reconciled a little bit better. Okay, I'm done talking. That was a long time. Go for it. Thank you all.
Oh, thank you so much for that. All right, so we'll open it up for questions. I'll start off. So one thing that I find hard with projects is to get that buy-in from all the different groups. And I know Steph mentioned like getting nursing buy-in and different things like that. How do you guys change how you talk about your project depending on who you're trying to get buy-in from? How do you guys navigate that?
I usually try to figure out what their why is within the frame of the project. So, you know, before launching on any project, I found it useful to sort of bring them all together, and, you know, and the more interprofessional it can be, the better, but to identify like, how do they feel about whatever the topic is, right? So whether it be, you know, transport for MRIs or OB hemorrhage or cardiac arrest, like, how do they think things are going? What are their concerns? What are they worried about? And usually somewhere in there, there's a whole host of things that we're all focused on. And that's usually a good starting point to get them to buy in, because then those are things that they want to fix too, and I want to fix. Or it may be like highlighting recognition that they don't realize, you know, oh gosh, our CPR quality isn't that great, or look at, we've done a poor job of getting the pads on our babies, right? And as soon as they realize, you know, that that's the case, they also want to fix it. So sometimes it's data sharing so that your why becomes their why. And then sometimes I think it's understanding their why and matching your why with theirs, if that makes sense.
I would say their why. Was thinking the same thing, but kind of their pain points and what specifically you will solve for them by doing it. And then kind of knowing the audience and how familiar or amenable they are to sim, I think, you know, really matters for how you speak to them about how, I mean, it's never scary to anyone, but kind of how much you're again emphasizing, like Steph alluded to or said, but about that framing around, this is a systems assessment. It's about making things safer, you know, not about any one person's performance, and just kind of hitting that home. And I'll say for the really complex sims, how I said we layer it, but like we often will do nursing if it's the first time we're ever doing some sort of in situ just with nursing, so that they have a little bit less guard up and feel a little bit less kind of under pressure than having the residents and attendings necessarily right with them. And then they're like, oh, this isn't so bad. This is literally what we do every day. Kind of like exactly what I tell them. This is what you do every day. So then when you kind of add them in with the other group, they just are a little bit more well-versed, and it's a little more bang for your buck also, versus trying to do it with everybody. And then you get all the performance artifact.
I think I struggle because I wish I had more I think as our hospital gets more money driven as everyone else's, people have less and more like metric driven, they have less time, energy, etc., to devote to things that might be seen as side or etc. I often, this is just small things, but I'll often find it can be easier just to approach people in person. Like when you happen to be on shift and they have a minute, you can just float an idea by them and get their like nonverbal and verbal reaction. If they're like, oh God, we're just launching this, like give it a month or two and then come back. That's super helpful, actually. That's great. And unless something is like really time mandated, like the move, then that's a different story. And I think would be brought up within the greater hospital structure. I think some of it depends on what's driving this, right? If with prenatal, we're moving in 2 months, we need to deal with this. What are your suggestions? That's a different conversation than, we've noticed precipitous deliveries bring everyone a lot of anxiety. We're going to do this in an effort to try and figure it out a little more.
If I can just build on that quickly, I was thinking while you were saying that, the question about do you frame things differently or speak to different groups? I think that the pitch to the front line directly is often different than the pitch to, like the nursing manager level people and up, because for them, it can be very much about metrics and quality committees and things that, make them look good and help meet metrics. And then I think to the front line, not playing on fears whatsoever, but a little bit indirectly it is, but talking about, especially with the high risk, low occurrence things like a precipitous delivery, you're one of the team with them and having the vulnerability to say like, it makes me wildly anxious. And I've been doing this a while. It kind of builds their buy-in for that too, because perhaps they don't care that much about the metrics. They just ultimately, like most, just care about giving great patient care. So that also kind of, I think, tailors the shtick.
Importantly, we didn't explicitly say this. It's got to be done on shift because we're talking about insight too, but it has to be done on shift. Doctors will do all sorts of things for free. So we're most students, nurses very understandably will not. And so figure out a way to work it in. I mean, I think that's great and good for them. And I'd like to volunteer less of my time, but.
I was just going to second what I'm hearing just about, there's sometimes, some people have experience with simulation and sometimes they don't. And naturally, the minute the word sim comes out of my mouth, right, the first thing that they go to is, oh, it's an assessment of me or an assessment or you're looking at me. So I would just reiterate, like, it's really making the emphasis around the team and how we're all going to be better. And I love that, bringing in yourself into it, right, has worked really well. I think their initial reaction sometimes is like, and especially depending on where they've come from, right? Because some places, they may have had some negative sim experiences in their training, et cetera. And so they might come into it fearful of going through a sim. And then as soon as they realize that it's not about them and, and sometimes it takes going through the sim to realize, like I've had nurses come to me after and be like, oh, that was really great. I love how we, did da, 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 da. And they were going into it thinking it was going to be a critique of them. And then as soon as they realized that this is just for us, all of us to be better and like look at the system and our processes, and it's an opportunity for, me to comment on how like the airway bags are in the wrong location and the meds haven't, can be fixed this way, that's really where the win comes. And some of it is word of mouth. Like once you have one successful event, people talk about it and they're like, oh, this is really great. And then the next one and the next one kind of builds on it. I think important to the success of getting buy-in is really being able to share sort of those successes early on with the teams. So if you got good feedback or you identified an intervention that sort of solved that pain point or addressed the pain point, putting that out there so everyone, even if they weren't a part of it, know that came out of that simulation and sort of adding to the benefit and value of participating.
Second that, but also if you notice people like maybe a group is more reticent or something like that, it's very reasonable and you should just be like, hey, I noticed this, what can I do to help? And you'll find things out that way too.
Does anyone have questions for our group or our panelists?
Hey, I had a question. And my name is Mike. I'm just a recent fellowship graduate. So I really appreciate you guys talking about your experiences because I'm someone who's very much in the kind of medical education, residency education side of simulation, and the idea of kind of going towards more quality improvement is something that's interesting to me, but I've never had any experience with. And I think all of your points were very well taken, that it's so inclusive of so many other different groups that have to buy in and have to be involved with your sim. I was curious for instance, Steph's sim with OB, if you're doing an in situ simulation, how do you actually who do you choose to participate in your simulation? Is it just whoever's on shift at the time? Like, when do you do it? Like, what are the actual logistical hurdles that occur when you're trying to dry run through something like that, and what type of data you're trying to get from it?
Sure. So regarding who is doing it from the ED angle, yes, it's whoever on shift, same with PEM, et cetera. OB had to have a second in line in case they were like in the OR, but that's what they would do normally. So it's actually all part of the process. And then, so from that angle, it was whoever there, same thing, nursing, techs, everyone. And we have like trauma team 1 and 2. So whoever was assigned to the team, same thing, who's the swing or the trauma attending, who's the trauma resident, who's the recess resident, who's the PGY1. Interestingly, like another thing to come out of this was it really isn't clear which resident is supposed to go to these. So we had a whole milieu of those, and that's like another small but very important angle of it, because you want at least one to come, right? And specifically which one. And same thing, nursing, everyone on there. And then as far as when to do it, that was a big consideration. And frankly, that was a big part of, I had to people who aren't ED don't get it. And so this is like my continuing learning here. They just don't get it at all. So I had to be very explicit about when to do it. And we knew right away it wasn't going to be, so there's limitations to this, right? It's not going to be overnight, because that's just, you're going to shoot yourself in the foot. It doesn't necessarily have to be at this point. We're just looking for general latent safety threats. We chose certain mornings at 8:30 to 9 o'clock, I think it was, because the trauma attending gets in at 8, then they have like teaching rounds, and then kind of the day starts. So we wanted it to be early enough before all the craziness that hits around 10 to 11. I think most EDs are included, but we wanted to have the trauma attending there. We wanted it to be late enough that everyone had rounded on the patients they got signed out on, but early enough that the rooms would be available, late enough that, again, the nurses get there at 7, so they're done, they have their assignment, they're sort of like stocking the rooms and available, etc. So when are the people available, when are the rooms available, those are the big, and then when would it be most likely to be accepted. And then fourth, sim crew availability, like they're not going to come in on the weekend for this. Again, something different, previous thing, like where it's like, okay, we're going to do this, it's going to be a 24/7 operation. Oh no, you better like, you can start with the nice daytime one, but then you got to like do the whole thing. You got to do it 24/7. And yes, everyone's going to grump, but that's critical because staffing is just different at different hours. Does that answer your question? Any other?
Oh, yeah, that definitely is a start for answering. I really appreciate that. I'm just imagining the difficulty in terms of getting, if you had some sort of quality improvement that you wanted to roll out and get enough participants to kind of show the types of ways that it might fail or get more feedback, the idea of running at so many different times at different times of day, and even having nurses say that they're even interested in doing it just seems incredibly challenging. So
it can be, but you can also do small bits. Like for the implementation one, how we wanted to see how people are using the CodeEB, I suggested to our QI person, like, well, why don't you actually just do a test run on the paging system and see if it actually goes out to the people? You know, things like that are so small you don't even think about it, but actually make a big difference. See if you can break it down in some different elements. I'm just going to make something up, but for example, let's say, we actually have our new like ED designed precipitous delivery bag with like a bowl, towels, scissors, gloves, and like B clamps, right? And that's it. And that's all. I don't have to go. I mean, you can do the whole thing. I can run it and bring the whole like scenario and record it and do all that. But I can also just a few times like have people look through it and say, what else do I need? Okay, next stage. I can bring in a prompt and, like the little like legs and just have them deliver the baby and say, okay, I want you to use this kit with this. Give me your feedback. It can be written, it can be verbal, you can audio, and then you can kind of amp up from there. So you can kind of start at smaller, and then maybe you bring in a couple nurses and do it that way. And then maybe you can do the whole kit.
I think it's amazing advice about keeping it super manageable. And this is where, if you're trying to do research versus, purely QI and assess and try to fix something, can be very different, but
very
absolutely
different.
Everyone's in the mindset a little bit when you run a sim, because classically it's true, like your case starts at a logical point and ends at a logical point. But especially if you want to focus on one piece of a case that would take 20 minutes, you can do those 2 minutes, especially if it's equipment you're testing, where it's like, okay, everything's been done except for this, ready, go. And like literally the only objective is just to open up the new bag and see their reaction, even kind of what's in it, and then debrief that is important. But you've got to start small and keep it manageable. Because I think some of the things I've learned along the way is you can lose buy-in so much faster than you can build it. And if you have like a mess of a sim, it's going to turn a lot of people off to necessarily wanting to do it again. I mean, things get messy and there's great ways to salvage that and just kind of own it in a debriefing if it goes that way, but don't set yourself up to have like way more to do than you need. And the other thing I would say to your question too is really leveraging partnerships creatively is important. So while we all have these things we dream of simulating because we know they could be better from the lived experience, everybody has a quality person in their department, and everybody clearly is a hospital quality person. Most people are mandated to do some number of QI projects in the department. Pitching it to your director that you want to look at something, this is your idea, but do they have others? Because this could be one of your 5. All of a sudden, you're making their life so much easier. And then it becomes theirs and it's shared. And then they're, gonna maybe help with the buy-in and talking it up and things like that. So really, whenever possible, also try to have a nurse champion. It's not my project. Me and so are so excited that we're going to do this today. And then the nurses are like, oh, it's important to you, but I see this leader that I respect who's, my own discipline is another good way. And they may do nothing other than stand with you. I have lots of people I co-debrief with because I want them to feel the ownership, but they don't speak. They really just stand next to me, and that's absolutely fine. But they can be, they're the content expert, the subject expert, etc. But really partnering when you're starting, I think is got to be just so important. And just being open to asking all the questions about, how can I help? These are my ideas. What are yours? This is where we can meet in the middle.
Yeah, I deeply regret not doing that because I was just so green. I didn't know to have those skills per se, but it would have been much stronger and frankly more interesting because the nursing is going to give you a different aspect of things, right? Pharmacy is going to give you a different aspect. Your QI person is going to be like, oh yeah, I've seen that's a problem, but and here's a technique we can try to look at it. And suddenly you have, especially from an academic or a publication angle, you have a different unique product that you can discuss, talk about, and disseminate, but also it's just more interesting, more fun, generally speaking, too.
Yeah, and a big thing too is having a nurse clerk, whatever the objective is, champion with you to ask them what their view of that clinical scenario is. Because if you debrief in the scenario and pay as much attention to something that is just nursing specific as what we all do naturally, that's very physician specific, all of a sudden the nurses see it as like, oh, this is actually debriefing for me too. I'm just not just an actor here to allow this doctor to educate these doctors. And I hear time and time again, many hospitals from nurses that can be the perception, which you could, I hope, see how we could set ourselves up for that, if we're not kind of deliberate in thinking about it.
Any other questions for our panelists?
I did have a question. My name is Joanne Agnad. I'm at NYU in Bellevue. For Preeti or for everyone else, about the sim where you're transporting your patient to another location, how did you go about just like figuring out how to do this logistically?
So it's a great question, and it kind of resonates with a lot of what we're hearing on the panel. Definitely a team effort. We had colleagues from PICU, NICU, respiratory therapy, pharmacy, nursing, nurse educators, all part of the team. And then I'm not sure if you're asking if this is the question, like, are you wondering about like getting through that space or like identifying the path?
I feel like most of the time the path is known. The concern is, all of the issues that might come across. Like you talked about potentially the anaphylaxis, but like an intubated patient that needs to go to the OR that has a dislodgement, like how much am I focusing on that?
Yeah, so we came up with that team, we identified common scenarios, things that do happen in sedated patients, non-intubated, obviously, such as, what if there's a laryngospasm, or what if you have to bag on the way, or what if your IV is lost? And then we did come up with scenarios in addition to that of, well, what if the, infant's breathing tube is dislodged? So we had a set of emergencies along the way that we had to address. Like, what would we do in that situation? Where how ready are we with our equipment? We think that we could restart an IV. Do we have everything that we need for that? And then the anaphylaxis piece really came out because we were entering an adult space that wasn't outfitted for pediatric patients. And then I think we also identified inadvertently some latent safety threats that they already had in there that would have been a safety threat for an adult patient as well, and that they didn't have the materials to actually treat anaphylaxis in their box that they thought that they had, right? So great that you have the epi, but you don't have the equipment needed to administer the epinephrine. And so that came out in that space. So a lot of it is sort of anticipating what you think the emergencies might be, and then letting them play out and listening to the team on what they think would have gone better, what solutions do they have, things like that. They come up with the great part about it is they come up with so many more solutions than you'll come up with on your own. They're just like this treasure trove of, well, we should do X, Y, and Z this way. And you're like, oh, well, I didn't think of that. That's amazing, because they're living and breathing it. And they really know the best way to get things done.
Thank you.
Last statement I would say is exactly how you get the buy-in of transport and RRT, respiratory therapy, to want to participate in the sim too, by really emphasizing that they're invaluable in that case. And without their perspectives, I could push the stretcher, but we're not going to pick up on all of the things that they see from really doing it day in and day out.
And you're never going to know if their badge will actually get them in the area, which comes up every time. Same thing with the OB, the precipitous delivery. Like, OB couldn't get in. It's amazing.
I have one last question for the panelists. So I remember in residency when they had mock codes that we did in situ, they really weren't for like QI. It was more just like the traditional mock code. The people who run it wouldn't necessarily tell people that it was sim, and because they wanted to test all the systems and things like that. And some people got very upset about it. And I just wanted to see if you guys tell people ahead of time, or do you guys do it just to like stress the system and see?
I know my answer because I feel like this could be an hour unto itself. And I get asked this a lot because I do a lot of insight too. But Preeti or Steph, what do you think? What do you do?
I'd say we've done it both ways, and some of it is about culture. So some of the ones I think in our PICU, it's just people didn't think anything of it. They arrived and they participated. But it has its pitfalls in that you have to be really careful about when you do that to make sure that it's safe to do so. And then secondarily, sometimes when people start realizing that that's what it is, they may not attend, or so it is a fine balance of when you choose to do that versus not. And I don't know that I have an answer. I'm still trying to figure out, I think it has been very helpful for us from a diagnostic standpoint. So when we did it originally, we did it really to establish sort of a baseline of where we're at with our pediatric cardiac resuscitation skills, and how's our team performance essentially in that space, and we did it so that it would inform future simulations in our educational program. And I think everyone knew that that's what that was for. And so we did a bit of a campaign to say, hey, this is coming, this is the purpose. Please do your best, everything the way that you normally would do it. We're really just trying to figure out what we need teaching on and what we want to focus our sims on.
It really depends on your goal. So for us, when we were looking at really LSTs, we needed to have a little bit of an element surprise. However, I had to consent people because it was a study and we were recording every day. So they got a few minutes, probably like half hour to an hour kind of awareness that it was happening. From their angle, they were like, oh man, because no one ever feels comfortable with it. So I think they would love to just go through and practice for educational reasons. But it really depends. If you're doing something to like test a system or get a true baseline of something, it's probably like from a science angle, it's best to like have less awareness about it, but balance that with your culture. And if you do that and people are never going to participate in it again and they're just not ready, then just start it and just say, we're going to do this for learning, etc.
Yeah, I just put a citation in that has a sample, but this is something from years of doing this. I've gotten people very upset. I would say never ever surprise anyone with an in situ until they're really used to seeing you and the mannequin or the standardized patient in the department and around, and you kind of have enough street cred that like it's worthwhile. But it really has to go back to objectives, because is it worth it? But if you're collecting time sensitive metrics, I personally don't think I ever would have felt like I could have gotten true the latent safety threat bundle and the metrics if I hadn't surprised people. But one thing that we started doing is we send monthly emails out that basically have all of our pre-briefing in them, that are like, at some point you may get called to an activation, and it may be a mannequin when you walk in the room. Approach it like you would a real patient. Know that it's about the system, not, you guys know the whole spiel. So that I've had people like run into a code and be like, oh, now I get the email, but then they actually just like go with it. And then I would say in the debriefing, the first thing I would say is like, thank you so much for rolling with it. I know it's super like jarring to be caught off guard in a sim, and then I always try to do at least a baseline kind of the pre-brief safe container stuff before the debriefing, because that's the real thing you lose, right? Surprising people is any of the like opportunity to establish the psychological safety. But that said, I just don't think that you can get the same information. So if your objective is to really see who shows up and how it works, you have to see who shows up and how it works, and if the operator answers and things like that.
So thank you for saying that. I would have never done mine without sending out a quick email to everyone, just being like, this is happening, this is the reason, it will be sporadic, you are not being assessed, it is a system, we all blah 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 blah, same thing. God, I would be murdered. I wouldn't be alive if
And if people are upset, you just continue to thank them and appreciate their participation. If they walk out of the room, this is what we do, right? You just like, we're all kind of winging it at all times, no matter how together people are portraying that things are. Something will always come up. That's the fun, the challenge, and the beauty. So, but yeah, I wouldn't like start off by catching people off guard. I know that probably goes without saying.
We're at the top of the 5 o'clock hour. So I want to thank again the panelists for talking about their projects. And I also wanted to highlight our next mentor hour. I put it in the chat. So we're going to be talking about academic promotions within SIM. And it's on November 21st at 3 p.m. Central or 4 p.m. Eastern. And then we're starting to plan out next year's SIM topics. And so if you have any thoughts about what you would like to hear about, just let me know.
And our emails are in the chat, or probably easily track downable, but I will only speak for myself, although Steph did too, but I'm happy to answer any questions as people get started or anything comes up.
Yeah, like most things, there'll be a lot of little questions, so don't be shy.
Absolutely. Same.
Thank you, everybody. Have a good rest of your night.
Thank you.
Thanks.